Hello, and welcome to the Multiple Sclerosis Association of America's live webinar, Best Practices in MS, What We Know, What We Don't Know, and What We Hope. I am Gina Murdoch, President and CEO for the Multiple Sclerosis Association of America, and your host for tonight's program. On behalf of MSAA and our presenter, we greatly appreciate the opportunity to keep you updated on this very important topic. And please know, we hope you and your family are staying safe and healthy in these uncertain times. MSAA is extremely honored to host this educational program with Dr. Barry Hendin, MSAA's Chief Medical Officer, the Director of the Multiple Sclerosis Clinic at Banner University Medical School, and Clinical Professor of Neurology at the University of Arizona Medical School. Before we begin, I want to take this opportunity to thank Novartis for making this webinar possible. As you may know, MSAA is a national nonprofit organization dedicated to improving lives today for the MS community. In fact, this year marks MSAA's 50th anniversary as an MS advocacy organization. Some of our free services include a national helpline, equipment and cooling products, MRI funding, an online community, webinars, and many more free programs available to people living with MS all across the country. Please visit our website to experience our new COVID-19 and MS Pathfinder tool, which provides ongoing updates and resources on the coronavirus. Also, please note MSAA has expanded our helpline hours to 8 p.m. Eastern between Mondays and Thursdays. To learn more about these and all the ways MSAA improves lives today, please visit mymsaa.org or call 1-800-532-7667. And lastly, please note tonight's program will be archived to our website very soon. For our Q&A session, please type your questions into the chat box and we'll address them at the end of the presentation. Also, if you are having any technical issues, please type those concerns into the chat box as well. We are so pleased to have you join us for this timely conversation, and I am honored to introduce Dr. Barry Hendin. Dr. Hendin?
Gina, thank you very much. I'm very pleased to be able to speak with such a broad audience, people with MS and people who presumably are supportive of people with MS. When we tried to figure out what we wanted to talk about today, the format we chose was one of trying to present what we really have learned about MS over the years that is science-based and really beyond opinion. And then after that, those things that we're still trying to work out and are still a matter of opinion, and in terms of clinicians, you'll see a lot of variation in how we interpret and do the things we do. I wanted to at least touch on those various interpretations that you will be hearing from neurologists and neurologists who focus on MS. And then where we hope we're going, where we want our understanding and our ability to treat MS, where we really are aspiring, what we want this to become ultimately. So that's the kind of the three prongs that we'll be doing. And then I hope that I don't speak too very long so that some of the questions which you all have put in advance, Gina has formatted, and I'm going to have her tee up those questions to me because they're actually excellent questions and focus on the sorts of things that I think we believe are the subjects that we ought to be talking about anyway. So with that in mind, again, I am really honored to be presenting for MSAA and an organization that I think you know has been one that has been so important in supporting education in MS, day-to-day needs of people with MS, and for me, it's to be able to walk along with and serve MSAA has been a real blessing, a real honor. So, what do we know? Well, I want to bring us back to the early days of MS, and certainly I was practicing before the 1990s, but until 1993, there were no therapies that were disease-modifying therapies. The first disease-modifying therapy was 1993. So before that, neurologists would diagnose, still with a reasonable degree of accuracy. We could treat some of the symptoms of MS. We could treat relapses, but we couldn't change the trajectory of MS. We couldn't say to someone, we're going to reduce the likelihood of disability. We're going to improve the probability that you will have a life of greater function and greater quality of life. As of 1993, we got our first disease-modifying therapy. I think it's important to recognize we now have over 20. But then there was first only one, beta-seron. Then there was Avonex, another interferon. Then there was Copaxone, copolymer. And then came an additional interferons and oral agents. But we didn't have enough experience to be able to answer the first question, which was, when should you start the therapy? You all who are listening may say, but that's obvious. You start the therapy when the diagnosis is made. But in 1993, that wasn't obvious, and there were varying opinions. A very conservative view, and it was led by the Mayo Clinic, was that MS was a long-term illness, a long-term disorder, a long-term issue, and therefore you shouldn't begin therapies necessarily early, but you should observe for some time to decide whether or not you needed to jump in with a therapy. Another group, and I have to admit that I was in the latter group, believed that we should jump in early and treat when we make the diagnosis, if at all possible. But it was still a debate, and I want to bring out that it wasn't yet. It was opinion rather than the clear information. The difference was we had data. So a number of trials were developed around what we called CIS, a clinically isolated syndrome. People who had one event, maybe optic neuritis, maybe partial transverse myelitis, maybe a brainstem cerebellar problem like incoordination double vision. And studies were done with the available agents to say, if you treat people with their first event, CIS, their first relapse, before they become multiple sclerosis, could you prevent the second relapse and the diagnosis of MS? And the answer was, in those studies, two things evolved. One, those early agents, compared to placebo, did reduce the likelihood of a second relapse and the likelihood, therefore, of being diagnosed with clinically definite MS. But the second one was an equally important finding, and that was that the people who were in the placebo group, who were then transferred to the treatment group 2 years later, never caught up. They always lagged behind in terms of disability, so that the answer became a solved or a clear-cut answer. If you delayed therapy, you ran the risk of creating disability that you would not be able to undo, and that people who were treated early really did benefit more. The people who were treated later never caught up. The answer was, you treat as early as practical for the diagnosis of MS. So we know that, I would suggest. The second thing we know is the importance of paying attention not just to MS, but MS on therapy. So if you start a therapy for MS, be that an oral therapy or an injectable therapy or an infusional therapy, it's important to monitor for two reasons, maybe three. One is monitoring for safety. Is the agent I'm using, which I'm hoping will be of more benefit than risk, causing safety problems in this one person? We know that in populations, based on the trials that were done, the things that people might experience. We know what might be experienced with each of the agents based on the research or the trials that we call phase 3 trials that were presented to the FDA. So one of the reasons we follow is safety. Is there a change in the various components of the blood count? Are there changes in liver function or kidney function? Is there an increase in infection or infection risk, including issues such as PML? So on one hand, you're monitoring blood work for safety. You're monitoring MRI for safety. But you're also measuring it or monitoring to see whether the agent you're using is doing what it's supposed to be doing. In the early days, there was a debate about whether we should call, if a person was on an agent and they had a relapse, whether we should call that a failed therapy. And we decided that that was actually the wrong term, that we use the term optimal and suboptimal. For example, if you started someone on an agent and they broke through, how did you know they wouldn't have broken through more often if they weren't taking the agent? How do you know that they wouldn't have broken through despite the agent? And so really it's about whether or not the agent you're using is doing what you want it to do. All of these agents are anti-inflammatory agents. All the disease-modifying therapies are what we would call anti-inflammatory. They're supposed to reduce inflammation. And our marker of inflammation, the one we use the most, the clinical one is relapse. The non-clinical one is MRI. So if we start someone on a therapy and the therapy has had time to work, we'll tend to get an MRI. People do it at varying times. 3 months to 6 months is generally what we would choose after starting a new therapy, depending upon how quickly the therapy worked. And then we'll look to see whether or not we've accomplished our goal of reducing the inflammation. If there is new activity that's currently very active at 6 months, we call that gadolinium-enhancing lesions, we know that despite our agent, 6 months later, when our agents by and large should be working, that there's still inflammatory activity going on, and we would say, it's not achieving, this agent is not achieving what I hoped for. And that is that I would achieve a sufficient anti-inflammatory response that I would not see inflammation. If a person's having a relapse, we would say this is a suboptimal therapy. You wouldn't say that a day or two or a week or two after starting a therapy because it hasn't had time to work. So what I'm suggesting is that you're monitoring for safety, blood work and MRI. You're monitoring for success in achieving the goal you set before you. And then you're monitoring by asking the questions about tolerability. Is this an agent that you're actually taking without it really interfering with your quality of life? That's clinical monitoring. So I would say that it is very clear that people on MS therapy need monitoring. The type of monitoring varies with the agent. We have agents that, one agent that does not require blood work but still requires periodic MRI. Another agent on the other end of the spectrum that requires blood work monthly for 4 years after you've gotten your last dosage. So that the monitoring requirements aren't identical for each of the agents. But the fact that you need to monitor is in fact a given for safety and for efficacy, safety and effectiveness. The next thing I think we know for sure is that the disease-modifying therapies are not sufficient in and of themselves, that there are other issues that create well-being in people with MS. There are other issues that we know lead to worsening outcomes that have nothing to do with taking your medicine or not taking your medicine, which is a given. So it's a given that you need to take the medication you're prescribed if it's working and if you can tolerate it, that no agent works less well than the one you don't take. The second part of this, though, is the need to continue on wellness and a general view of health. So we know that smoking leads to poorer outcomes in people with MS. If you've got MS and are smoking, you're doing something that is, in fact, counterproductive. You are taking your disease-modifying therapy and simultaneously doing something which is working against disease modification. We just believe that one of the most fundamental things you can do is stop smoking. Second, exercise. We believe that exercise promotes general health and also improves function and outcomes in MS, that people with MS who exercise do better in terms of disability than people who don't exercise. We believe that a healthy diet and maintenance of a good body weight becomes an important part of outcome. And we know, for example, that obesity is associated not just with poor health in general, but more disability in MS. And so what I'm focusing on here is that the disease-modifying therapies are the important base, but they're insufficient without a comprehensive disease management. And that means diet, exercise, that means stopping smoking, taking vitamin D. That means managing symptoms to improve quality of life. That means managing what we call comorbidities, and that means diabetes and heart disease, et cetera. Not managing those other medical conditions leads to worse outcomes in MS. So as a given, what we know is that the disease-modifying therapies are essential and insufficient in and of themselves, and that we have to take care of the whole person. That means how they eat, how they exercise, how their general health is, how they stopped smoking, and their mental health. And that is watching for depression, watching for anxiety, treating those, managing symptoms, managing bladder, et cetera. Again, a given. I think it is increasingly part of our understanding about when we should not just start a therapy, but when we should consider changing a therapy. And so I alluded to the fact that if you're on a therapy that isn't working, not doing what you want it to do in terms of stopping the inflammation, that it is a time to talk with your clinician about, am I on the right medicine or do I need something more effective? If you're taking a medication, and that means both by MRI metrics and by clinical metrics. If you're breaking through clinically, you are not achieving optimal therapy. If you're breaking through with new MRI lesions, you're not on an optimal anti-inflammatory strategy. So that's one part. The second part is, are you tolerating the medicine? I tell people periodically that when I started disease-modifying therapy, I'm saying, you'll thank me in 20 years. And I also say you won't thank me in 20 years if you're miserable every day of the next 20 years. So whatever I start them on has to be something that is tolerable. There are people who take medications like a good soldier that they're having a very hard time tolerating. We should be able to do better, and you should ask us to do better. They may have stopped their medicine because they couldn't tolerate it. That's part of a conversation. We should do better. You should expect us to do better. You should ask us to do better. So if you can't tolerate your medicine and aren't taking it, ask us to do better. If you can't take your medications, if you can't tolerate your medication and are still taking it, talk to us about change. And then the last thing for change is if we're creating hazard, if the medicines we're using are creating dangers, that they are creating liver damage or changes in blood work that is not healthy, changes in really the general health of an individual. So it should be health. It should not reduce health. It should not reduce quality of life, and it should work. And if it isn't, we've got enough therapies right now that we would be talking about change. What don't we know? Those of you who are listening, if I could poll you, we would hear that some of you are on injectable agents, some of you are on oral agents, some of you are on infusible agents. I would venture, without having the ability to poll you, that you are on multiple different agents, which means that there is no consensus about which one agent is the right agent for you, which one agent is the right agent for populations. It's lucky, therefore, that we've got so many agents to think about. I have in the past compared myself to a shoe salesman and have said that my job is to find the right shoe for the right foot, the right therapy for the unique person in front of me. And that means a discussion about not just what I think is the right therapy, but a discussion about what the person in front of me would like to take, their fears, their goals. So it is a collaborative process. One size does not fit all. But the question is there an evolution in our philosophy of treatment? And I would suggest that there is an evolution, that we know that the injectable therapies, while having a high safety record, had a lower record in terms of power for reducing inflammation, and that there has been an evolution toward higher efficacy agents, whether that means the oral agents, the infusible agents, or I would say now the new injectable agent, which is also a high efficacy agent, and one that was just approved in recent weeks. So the platform agents still are used, but a tendency to move toward higher efficacy agents, often those which have evolved after the first platform agents. So if you said to me, do I believe that there is data to suggest that there is benefit in the higher efficacy agent for most people? The answer is yes. Is it opinion and still a part of the discussion that goes on across the country? Yes. Despite the fact that I might believe that, do I start all patients on high efficacy agents? The answer is no. After discussions, my practice is to try to take into account the opinions of the people I see and also their unique clinical profile, which leads us to the next bullet point, and that is, do we treat to the presumed prognosis? That says to the presumed diagnosis. It should say, should we treat to presumed prognosis? We have some indicators, imperfect, as to people who are likely to have a milder course of MS and people who are likely to have a more serious course of MS with more hazard. Our predictive indicators are imperfect, and because they're imperfect, we can't say we can tell from your presentation that you will do well or won't do well, but we have some indicators that tend to lead us in the direction. I would say that most neurologists tend to treat more aggressively with higher efficacy patients if they think the prognosis is worse, and some use milder agents if they think the prognosis is better. I would say that based on studies that have been done in recent years, using higher efficacy agents when compared to lower efficacy agents has the same kind of outcome that I told you about the original trials. Some of the newer trials have compared higher efficacy agents with what we would have called the platform or lower efficacy agents. Both reduce, they're called active comparator rather than placebo comparators. And what they've tended to show is, again, they both work, but the higher efficacy agents work better over the 2-year period of the trial, and that when looked at in terms of long-term extension observation of that population, once they're switched over all to higher efficacy, the groups that were treated with lower efficacy agents don't catch up. So again, not solved, but with a tendency, I think, in the MS focus community to use more effective agents earlier than had been the pattern earlier. When to stop therapy? We know that MS becomes less inflammatory as people age. So the immune system, there's something called immunosenescence. Immunosenescence means that your immune system is less and less powerful as you age. For MS, it is a helpful thing in that the autoimmune system is less and less powerful as you, autoimmune system is less and less powerful as you age too. People after their 50s and 60s and 70s are less likely to have relapses, less likely to have inflammation, and one of the debates right now is, should we de-escalate and therefore use a less potent agent as people age? Maybe. Should we stop therapies in some people as they age? Maybe. Do we have the evidence to show that definitively? Not yet. There's a study going on at the University of Colorado. The head of that study is Professor Corboy. He's looking at people aged 55 to 65 who have been free of relapses or MRI activity for a period of years, and half of them are remaining on therapy and half of them are stopping. For him to answer the question, are we doing enough good to balance the harm in the therapies as people reach certain ages? It still we'll know about populations, we'll know about what ages tend to be the least risk for relapses and the most need, therefore, for ongoing or the least need for ongoing therapy. But the individual in front of me will always be unique, and I'll have to answer that question always. Yes, you're 50. What should we do about you? You're 60. What should we do about you? You're 70. What about you? Populations will know. Individual people. Still, as always, it's an ongoing discussion. So what do we hope for the future? We hope that we'll be using something besides MRI as biomarkers to tell us about prognosis. One of the indicators for prognosis that I talked about was MRI, but we're looking for inexpensive blood tests that may tell us something about whether a person is having a lot of inflammation or a low level of inflammation. The prime candidate now is called neurofilament light. Neurofilament light is a breakdown product of the neuron, of the skeleton of the neuron, and when a neuron dies, it's released into the spinal fluid and then into the blood. We've got now very sophisticated tests to see what the level is in the blood in order to determine the level of inflammation that may help us determine prognosis in an individual. Do you need a highest efficacy agent? Might you get by with a lesser agent? We're looking at other markers as well that deal with the glia and the astrocytes to tell us about prognosis. But they may also be helpful in telling us about whether or not a particular therapy is working. People will often say to me, how do I know if my therapy is working? And I tend to say, is your MRI okay? And are you feeling okay? And if you have relapses and are you stable, it's working. But the other way of looking is to look to see whether there is a breakdown in the neuron. So if we see if we have markers like neurofilament light that show a high level of breakdown despite a therapy, it may be a reason for us to say, this is not doing the work we wanted to do, and not just require an MRI. The future, we're hoping we've reached a level where we have been really good at reducing inflammation and attacks. We're still working on progression. We hope to do better with progression. And this says in the future, we're hoping that we'll also be able to repair injured neurons and allow for remyelination. There's work going on, and some of the questions which were posed to us today by you all were the question about what's the state of the research in remyelination? What's the state of research in terms of repair? I'll be happy to talk about that when Gina tees up questions for me. But I think we are not yet there at a level that we can confidently tell someone that we are repairing and remyelinating the central nervous system, but we really have made great strides. And then in the end, we still need to understand what are the variables that cause MS? We know that there is an inherent vulnerability in some, genetically based, in terms of how many genes are protective versus how many genes are susceptibility genes. So we know a bit about the genetic susceptibilities. We know that they are not determinants in terms of your genes will not tell the whole story. And there have to be triggers that are going on in the environment, whether it's EB virus, whether it's cigarette smoking, whether it's lack of vitamin D, et cetera, et cetera. Those are the things that are triggers. And so what's the cause? We know some of the genetics, but not enough. We know some of the triggers, but not enough. We really are looking toward a time when we can say we understand the cause of MS sufficiently and the triggers sufficiently that we can cure or end MS. And that's ultimately the goal for all of us, the end goal. So those are the things I wanted to say. Those are the things that are the questions I ask myself virtually every day. I'd now like to be quiet in the remaining, I think, 25 minutes or so, and answer the questions which you posed in advance or which are on the question block. Gina, your thoughts?
Wonderful. Well, thank you so much, Dr. Hendin. We really appreciate your perspectives, your compassion, and spending your time with us. So wanted to go to some of the questions that we have. We have some questions sent in advance and some that have come in the chat box. So one of the first ones that we have, and there was a number of people that asked this, talking about, can you explain a little bit more about secondary progressive MS and what the difference between active and inactive secondary progressive MS is, and whether relapsing remitting treatment should ever be considered for secondary progressive MS?
Sure. So the first thing is definitional, and that is, what is progression, and how do you differentiate the forms of progression? A lot of work was done by Dr. Fred Lublin at Mount Sinai in New York in trying to really define these terms for us. And so with a tip of my hat to Dr. Lublin, to Fred, we would say this, that there is a group of people who never really experience a significant relapse pattern, that they don't have an onset with optic neuritis or a spinal cord injury or brainstem injury, as the people with relapsing MS do, but rather have a very slow, insidious onset. That's primary progressive MS. MS without a relapsing history. That's 10% or 15% of MS. The 85% of MS is the relapsing form of MS. A number of people who have relapsing MS will go on late to what's called secondary progression. So the typical is for the early years of relapsing MS to be punctuated more by the inflammation, relapses, with improvement or even return to baseline after an attack. And then if there's a failure to return to baseline, at least a stability after that. There is a phase later in MS where, despite the lack of relapses, people tend to say, I'm not as good as I was last year. My legs are weaker, my coordination not as good, et cetera, et cetera, et cetera. That worsening, independent of relapses, in people who had relapsing disease to begin with, is what we call secondary progressive MS. For me, the most hopeful part of the whole issue of secondary progression is the amount of attention we're now paying to it. So I want to turn back the clock in a couple of ways. One is, again, when I was a young neurologist, we couldn't treat relapsing MS. We didn't have any disease-modifying therapies, and neurologists were known for being nihilistic, and that is, they would say we really can't do anything. It wasn't true, because they could still deal with the symptoms of MS. But there was a lot of lack of appropriate energy and focus. That changed after 1993. There was a lot of early literature that said if a person starts to show disability, walking problems, for example, that at that point in time there wasn't much that we could do. So 20 years ago, even after the disease-modifying therapies came out, there was a nihilism about progression, and that once you saw significant progression, that was really all you could do. One of the things that we've been seeing, and I would say that the trials of one of the agents, in this case Siponimod, which was for secondary progressive MS, showed us that there was the ability to treat people with a high level of disability up to EDSS scores of 3.5, 4.5, 5.5, 6.5, and that we could, in fact, produce a better outcome, less disability progression in people who already had substantial disability. So my view is that the recent studies have been powerful at telling us, don't give up, there's more we can do. What the FDA said was there are two phases of secondary progression. One is the phase where there is still relapses despite progression, or there's still new MRI activity despite progression, or at least activity within the previous 2 years. And that's what the FDA is calling active secondary progression. So virtually all the agents we're now seeing, so virtually every agent, and I have to hesitate to think if there's one that doesn't have it, will say that it is approved for relapsing forms of MS, including, in some cases, CIS, in all cases, relapsing MS, and what they're calling active secondary, which I've just defined as secondary with some level of activity during the past couple of years to mean relapse or MRI. We've shown we can make a difference with our agents, and that means with the agents that are commonly used. For me, it is something that tells us remain optimistic when there is progression, particularly when there's active progression. There is more we can do with our disease-modifying therapies to change outcome. We've seen less and less disability in the current era than 20 years ago, 30 years ago, and that's because of the agents we're using and because of the increased effectiveness of the agents we're using. A long answer, but it is about this. Active secondary progression is when you've had a progressive phase, but still, it's in the past 2 years, some form of activity, MRI or clinical. The most important message is it's still a time when we need to pay attention, when our agents still work, and we ought to be very attentive. The biggest gain for me is that sense of optimism about what I can accomplish in that state, which wasn't so clear years earlier. Thank you, Gina.
Thank you, Dr. Hendin. A next question, and a timely question, talking about what your thoughts of someone living with MS and COVID-19 vaccine, especially in the halting of the AstraZeneca trial, and just kind of what your thoughts are on that subject.
So the things that the first thing I sometimes find myself quoting Bob Dylan in the line from the song "The Times Are Changing," which is, "Don't speak too soon. The wheel is still in spin. The losers now may be later to win, and the times are changing." So the virus has been with us for the last 10 months, and we don't yet know enough, but we're evolving better and better understanding. The givens that we now say are the following. We do know some things, again, if you go to what we know and what we don't know. We know that you reduce the likelihood of catching it if you wash your hands, if you wear a mask in public places, if you practice a sensible social distancing, that those remain sensible ways to reduce the likelihood of getting COVID-19. It looks like people with MS are no more likely to get COVID-19 than the general population with the same levels of ability and comorbidity. It looks like the people at the greatest risk are at greatest risk because of their age. The older you get, the greater the risk, and their comorbidities. Smoking, kidney problems, obesity, high level of disability, and untreated diabetes, untreated heart disease, untreated lung disease. So the big driver doesn't appear to be MS, but level of disability does play in, and comorbidities and age play in even greater. With respect to the disease-modifying therapies, although the original worry was that one particular therapy might be better or worse than another, the tendency for us now is to say that that MS is the greater known risk, and that we would not have a person stop their therapy, nor change their therapy. So don't stop your therapy or change therapy, certainly without talking to your clinician. The data we have so far, including the data from Washington University, Dr. Ann Cross, COVI-MS, her survey of the American scene looks like the risks are not excessive with the agents that we're using, and that we tend to keep people on their agent. With respect to vaccination, we don't yet know what the vaccination will look like. We think it will be a non-live virus, but we don't know that. We think that it will provide a degree of immunity, but we don't know how perfect that degree will be. We don't know how long lasting it will be. These are questions to be answered. The AstraZeneca paused because apparently, and I don't have all the information on this, a person developed a transverse myelitis, a serious repercussion, a serious sequelae of the therapy. So it tells us that it is appropriate for all the makers of the vaccinations to continue to do what they're doing, that is proper phase 3 trials with placebo control to see whether it is safe and effective. And I believe that by the first of the coming year, we will likely see a non-live virus which is partially effective or substantially effective in much of the population. And if the question is, will I be willing to stand in line for it? The answer is yes. Will our MS therapies in some way mute the response to those vaccinations? Number one, you can't tell for sure without knowing what your vaccination is. But some of the B-cell depleting therapies may mute or reduce the immune response. But we'll find that out with time. A long answer, mostly we're still waiting to know.
Wonderful. Thank you so much. So if we could circle back, there was a number of questions about remyelination and where we are in that research. So if you could address that.
Sure. And I participated in some of the remyelination trials. But let me tell you, we know that people with MS, after an episode of demyelination, try to remyelinate, and that their ability to remyelinate is diminished compared to the general population. The older you get, the less and less effective it is. There's a gene that reduces remyelination called LINGO. So the first attempt to try to remyelinate was to block the gene that blocked remyelination. The trial has mixed results, and I was in that trial, but it's still ongoing. And that is there a way to create remyelination through blocking the gene that prevents it? Again, work in progress. Work out of the University of San Francisco is looking at a wide variety of commonly used therapies, including clemastine, an antihistamine, which looks like it has at least some ability to promote the remyelination. A work in progress. Some of the work right now is really looking at the cells that create myelin, the oligodendrocytes. There are precursor cells, and so some of the work is, can we find the ability to grow the precursor cells direct them to where they need to be, and then turn them on. So there are a lot of different strategies. And hold on just a second, my computer wanted to, good. So there are a lot of strategies right now, and the question really is, which strategy is going to be the successful one? I believe we will ultimately have a successful strategy. It won't be tomorrow.
Okay,
Gina?
thank you very much. Yes, I'm sorry. There were a number of questions addressing fatigue. And one says, I always hear that exercise is good for MS, but my fatigue makes it difficult to move sometimes. Is there any advice you can offer about overcoming this obstacle?
Sure. And I'm going to talk about fatigue. Again, as you noticed, I will give you long answers for short questions. But my answer here is, everybody, I think, knows that the most common symptom of MS is fatigue. Fatigue is not unique to MS, and people who don't have MS also experience fatigue, but generally for reasons they understand. They'll say, I didn't sleep well last night, I pushed too hard at an activity, or was too stressed, or something else that will explain it. The problem with MS fatigue often is that it is there independent of the things you're doing, your sleep or your physical activity, etc. So the first thing is, MS fatigue is different from general fatigue in many people. The second thing is, I keep on saying, don't think about fatigue as a simple thing, but ask the questions as a clinician or as a patient about where the fatigue comes from. So in addition to MS fatigue, we might say there are things that people experience, and maybe even more so people with MS, that add to fatigue that are treatable. If people are having bladder issues that don't allow them to sleep a full night, and they're up at all hours not sleeping, that's going to increase fatigue, a reason to pay attention to bladder, a urologist. Some people are fatigued because of the medicines they're taking, including the benzodiazepines for muscle spasm, including some of the other agents that we're using may increase fatigue. The medications used for pain may increase fatigue. It's worthwhile to look at the medications and see whether they could be playing a role. Number three, if there's depression going on, and depression goes on commonly in MS, if there's anxiety going on, and anxiety is common in MS, that can increase fatigue. All the more reason, again, to start to pay attention to mental health. And if there is significant anxiety, depression, to go for, that's a treatable disorder. Both are treatable and a reason to treat. As I go through these things and say, pain is fatiguing, insomnia is fatiguing, bladder dysfunction therefore can be fatiguing, medications can be fatiguing, depression can be fatiguing, anxiety can be fatiguing. It's important not just to say I've got MS, I'm fatigued, but to try to look for other things which may be adding to it that are treatable. Number two, MS fatigue is treatable, and we use a lot of agents with some partial success, the Provigils, the Nuvigils, et cetera, et cetera. But the question was predicated on exercise, and so I would say, as part of a wellness routine, we believe that exercise is actually important. We believe that diet is important for fatigue. Obesity adds to fatigue. Healthy diet reduces fatigue. We think that that exercise reduces fatigue if it's approached properly. So I wind up saying to people in my practice, if I told you to go out and run, or walk half an hour or an hour, you A, might refuse to do it, and B, if you were willing to do it, you might be in bed for the next 3 days. And so it's important to begin with a very, very modest exercise program that you're willing to do. If you're a person who's willing to swim but not run, then swim. If you're a person who's willing to do a treadmill at home but not go outside, that's what you should do. If it's upper body exercise that's more appropriate, that's what to do. but find a form of exercise that works for you. Start out with modest increments and then build over time. If you try to start out full force, you will create fatigue. If you begin with slow increments, something you're willing to do and keep at and that you like doing, it should reduce fatigue in many people. But there is no magic bullet, one size fits all. And even when we treat the fatigue of MS, it's not that we make it go away, it's that we mitigate it. But there are a lot of strategies. Don't be superficial and don't be pessimistic.
Thank you. Another question we have a couple of times is asked, how do you know that the medication is really working?
So, it's hard. So it's a question that I think is actually hard to answer. People who are doing well will say to me, I'm doing well, but mightn't I be doing well even if I weren't taking the medication? The answer is, yes, it's true. We don't know in an individual. So in populations, we know the medications work. The disease-modifying therapies wouldn't be available if they hadn't passed scrutiny, scientific scrutiny, and been approved by the FDA. In the individual, it's a little harder, but I would say my gauge, my litmus test for is it working is the following. If it's a medication that's anti-inflammatory and you're not having the signs of that we use as MS inflammation apparent, and that means you're not having relapses and you're not having new MRI lesions, then we presume that the agent is working. And the data tells us that people are doing better now that we've started agents, the disease-modifying therapies, than they did 20 years ago or 30 years ago or 40 years ago. Certainly better than they did before we had these agents. Also better than they were doing before we had more effective agents. And so we know in populations they work. In the individual, my question is, are you having attacks? If you're having attacks, it's not working, at least not optimally. If you're not, it's doing what I want. Are you having rapid progression? If you are, it's not doing what I want. Are you having new MRI events? If so, it's not doing what I want. We have lots of choices if they're failing. But if you are stable and your MRI is stable, then the assumption has to be it's probably working. And I don't want to find out the opposite by getting you out, at least during your early years with MS. When a person is I'm a sufficiently senior neurologist to say, there's an agent at which I think we can ask the question that is it still working at my age and do I still need it? That was an earlier question that I tried to address.
Thank you. There was one question, and the person said they've been told to take vitamin D by their neurologist, and they've been taking D3 for a while. And what would be the difference between D and D3?
So I became interested in vitamin D in the 1970s and have remained interested in vitamin D ever since that time. I think we've got good evidence that people who have higher levels of vitamin D in their blood do better than people who have lower levels of vitamin D. We mostly believe that giving vitamin D is appropriate, although some of us note that we've never subjected the same kind of scientific rigor that we've devoted to the disease-modifying therapies. So most of us who treat with vitamin D, and the way we determine whether it's really the right vitamin D is blood level. Normal blood levels in most labs are 30 to 100 units, and I tend not to care what formulation of vitamin D you use to get there. I tend to like people in the higher range, between 50 and 100. Lots of my patients are on 5,000 units a day, but not all. And I take a blood test at least periodically to see whether I've kept them in that range. With the sense that vitamin D is probably helpful in MS, and certainly is a good thing for people in their bones additionally. But again, I don't care the formulation, I care more about the blood level.
Wonderful. There one more, and I think we have time for one more question. Is there anything other than Botox or Interstim to stop incontinence? This person has tried both and have not had great success.
So I think there are a wide variety of things that can be used for mild or moderate or severe bladder dysfunction. For mild dysfunction, it can be the medications, the ditropans, the Myrbetrix, et cetera. My sense first is that when a person's having incontinence, that the neurologist should be sending them to urology so that they can have a proper evaluation of bladder, a cystometrogram, so that we know why the bladder is problematic. And how we address a bladder depends on what is really causing the incontinence. Sometimes it's a very large bladder with overflow incontinence, or a very small overactive bladder that's causing incontinence. So number one, if there's incontinence, we need a urologist, and we need to understand the physiology of the bladder dysfunction. Once we understand that, then there are a wide variety of things that can be done addressed to the specificity. In more severe cases, Botox can be used, stimulators can be used, but the urologists really do have a variety, and clearly some people are using intermittent catheterizations, et cetera. If I summarized, I would say again, there's no simple answer to incontinence depending upon why the incontinence. The neurologist will not be able to answer that as well as the urologist with a bladder test, a cystometrogram. Once that's done, then the options become clear. But for some people, it really is that it's Botox. For others, a stimulator. For others, it's intermittent catheterization. That's a discussion with your urologist.
Wonderful. Well, we are at the top of the hour, so that will conclude tonight's webinar. I would like to once again thank Dr. Barry Hendin for his insights into the MS landscape. I would also like to thank our funding partner, Novartis, for providing support for this program. As mentioned, tonight's webinar will be archived to our website, and we ask you to take a very brief survey that is coming up next. Our funding is really dependent on our valuation, so please take just a couple of minutes to answer a few questions for us. On behalf of MSAA and Dr. Hendin, we thank you so much for joining us this evening.
And thank you.